presenters. We have two amazing women. We have Iris Pruitt Rubio, and we have Dr. Jacqueline Duget. I'm going to be telling you a little bit about each one of them right before their segments. So I just wanted to take a moment, and ladies, if you could just, identify yourselves, and then we're going to continue. So I did want to include this statement because this session may contain some sensitive information and content. And so while it's informative, it may or can be triggering to some of you. So we just want you to know that we acknowledge this, and we hope that you seek support as you need to do so. Okay, so here are today's learning objectives. We're really excited about the content that we will be presenting, or I should say that the speakers will be presenting. But during the webinar session, you will be able to examine the mental health impact of the Black and Latinx Superwoman Schema, comprehend the perceived benefits and problems related to the Superwoman Schema, build an awareness and understanding of the strong Latina woman, including, or we're going to be also delving into the concepts of machismo, Marianismo, familiarismo, respeto, simpático, and as well as self-silencing. You will become familiar with the imposter syndrome. And this is the most important part of the session, is discuss strategies to improve the mental health of Black and Latinx and Hispanic women. Those are the learning. I know it sounds really ambitious, but I'm sure we will be able to do so. Okay, so now we are going to move into our first segment, and it's time to begin by introducing Dr. Jacqueline Duget. Dr. Jacqueline Duget is a pediatrician, writer, and speaker. She's a child health expert on the issues of the impact of racism on children's health and helping parents to talk to children about race and racism. She's been featured on the Today Show, CNN, in the New York Times, in the Washington Post, and NPR. In addition, she's a co-author of the American Academy of Pediatrics policy statement called The Impact of Racism on Child and Adolescent Health. When she's not writing, she hosts What is Black, a parenting podcast that addresses issues important to raising healthy and thriving Black children and teens. And the book Learning to Love All of Me is her first middle grade novel. Okay, and so right now, I'd like for all of you to join me in welcoming Dr. Jackie Duget. Dr. Jackie, I'm going to stop sharing my screen so that you can share yours. Take it away.
Okay. Thank you so much, Brenda, for that introduction. So please bear with me with some of the technical handoffs. All right, so let me do the presentation first. Okay, so as Brenda introduced me, I'm Dr. Jacqueline Duget, and a pediatrician by training. But I think what's interesting, I was excited to be asked to talk about this because I think, sometimes being a pediatrician, for the most part, I care for children, but I also care for parents as well. And knowing that there's an intergenerational lens that we can look at the Superwoman Schema. So we'll start out first by talking about this, talking about the implications for the Black Superwoman Schema, and then later on touch on some of the intergenerational issues that we need to look at. All right, so this is where there's some technical issues. All right, so I'm going to stop sharing and share a video that I wanted to have pop up. Hoping that this will share. Yeah, this will be fun. All right. All right, so I want to play this video just for a few seconds, just to provide some context for what I'll be discussing.
Everywhere I'm turning, nothing seems complete. Stand up and I'm searching for the better part of me. I hang my head from sorrow, state of humanity, wearing on my shoulder, gotta find strength in me. 'Cause I am Superwoman. Yes, I am. Yes, she is. Still put on the best, but it is so much. Oh yes, I'm a Superwoman.
Pull back up the PowerPoint slides. And so we talk about this idea of the Superwoman concept, right? And this this idea of being a Superwoman has been, is really throughout our culture, right? As noted by this very popular song, Alicia Keys, Superwoman. And for many of us, if we like Alicia Keys or like, or listen to her music or the lyrics, like the lyrics resonate with you, and even the tone of the song is really an anthem, right? And again, it's a great song, but I think it's important to really look at this idea of the Superwoman and diving more into this notion of what it is to be a Superwoman and why it is we have this ideal of who we are. Before I go any further, I wanted to know, by those in the chat, I'm just going to ask a quick question. How many of you wear a cape almost every day? Or how many of you have an S on your chest, like the lyrics in Alicia Keys' song? Okay, a few people are raising their hands, and I can probably say the same thing, right? I think even before, having this understanding of this role of Superwoman, I definitely, wore cape with pride. And I remember, watching when my kids were younger, an animated film, right, called The Incredibles. And one of the characters in The Incredibles asks, one of the heroes asks the designer of their suits, why don't I have a cape? And then the designer of the suit goes on to show examples of several superheroes who unfortunately had an untimely ending because their capes got caught in something, either a plane or, the villain snatched them because of their cape. And so she ultimately told the superhero, no cape, no cape. And again, those sort of references in media, really spoke to me. And it's true, right? Your cape can be caught on things, right? And sometimes it's inconvenient, but sometimes it is convenient, right? So I guess there's this duality of this role of Superwoman, right? This role of Superwoman does have positive and negative impacts and effects, right? And benefits for both Black women and Latina women or Hispanic women might be, right? It helps us to cope with stress of racism, gender-based discrimination, but there are also consequences to this, this idea of taking on this mantra of Superwoman. So I wanted to, I love this quote from one of doing the research from the articles I found. And this particular quote, the stereotype of the strong Black woman is more than just a cultural trope. Many Black women in America report feeling pressure to act like superwomen, projecting themselves as strong, self-sacrificing, and free of emotion to cope with the stress of race and gender-based discrimination in their daily lives. So again, this is where that double-edged sword, where there's some benefits of being a superwoman, right? Because historically, and we'll talk a little bit more about that, why it is we've had to take on this role and ideal of being a superwoman. So this is a conceptual framework of the Superwoman Schema, and it was developed by a professor and psychologist, Dr. Cheryl Woods Giscombe. I apologize, I'm mispronouncing her name. And she developed this schema to fully understand more about how stress helps African American women cope, especially given the constructs and context of racism. When she developed this conceptual framework, she discusses that there are 5 characteristics to this superwoman role. 1, an obligation to manifest strength, an obligation to suppress emotions, resistance to being vulnerable or dependent, a determination to succeed, and an obligation to help others. And throughout this framework, she builds on, she scaffolds this idea of the superwoman ideology, reasons why we had to, why this superwoman role developed, right? Their contextual factors, historical legacies of racism, sexism, stereotype, things that we learn from our foremothers, right? What's passed down, maybe our spiritual values, our experiences with the church, or our spiritual practices may also inform this idea that this is the role we must take on. And then I talked earlier about this balance of benefits and perceived liabilities or negative consequences. All right, so this idea of the perceived benefits of taking on this superwoman role, this idea of preserving yourself and survival, right? Maintaining your identity, relishing and loving who you are, preservation of the community and our families. But again, we look at this balance in taking on this role, the liabilities these perceived liabilities, right? We can have strains on our personal relationships. Also, stress-related health behaviors that can lead to poor health outcomes, poor sleep, eating, lack of self-care. And then also some of the health outcomes that we'll talk about later. So again, we're going to explore a little bit more some of the health consequences of the Black superwoman. So this quote says, "Strong Black women is a mantra for so much a part of the US culture that is seldom realized how great a toll it has taken on the emotional well-being of the African American woman. As much as it may give her the illusion of control, it keeps her from identifying what she needs and reaching out for help." So this next slide is taken from a research article by Dr. Armani Allen and her colleagues. It's called "Racial Discrimination, the Superwoman Schema, and the Allostatic Load, Exploring an Integrative Stress Coping Model Among African American Women." So in some of the work that I've done, Brenda alluded to a policy statement that I co-wrote about the impact of racism on children and adolescent health, right? So when we talk about allostatic load, we're talking about what are those stress factors, right? We all experience stress, our children taking tests, we're about to get our driver's license, we're about to get married, all right? So those are somewhat positive and normalized typical stresses. But then there's some stresses that are so impactful on our bodies that it can predispose us to having chronic health conditions, right? So one of those factors that can increase the stress on our body is racial discrimination and racism. So the authors of this study they examined whether the Superwoman Schema modified the association between racial discrimination and allostatic load. Sciences and studies have already showed that if you're exposed to racism, whether it's direct or indirect or vicarious racism, that's going to increase your stress, and that automatically will lead. There is a sort of quote unquote linear relationship, right? As racial discrimination increases, your stress increases, and then your risk factors for chronic disease also increase. But in examining this, right, this study really looked at, rethinking about, is there really this linear relationship, right? How does as they say, how does racism get under our skin, right? How does it impact our health? And there are other factors that may contribute to how we experience stress or cope with stress. And so what they found was, again, these five, the motivation to succeed, suppressing emotions, strength, resistance to vulnerability, and caring for others are, again, those key characteristics of the Black woman, Black Superwoman schema. And so in their research, they found that women who suppress their emotions and show increased strength, present an image of strength, these are actually protective factors. One might think that, okay, you know, this seems kind of counterintuitive, but what they're finding what they found in the research with the African-American women they worked with and that participated in the study were that suppressing emotions, if you get angry, right, anger in itself increases stress and can lead to poor health outcomes if you're constantly angry. So this coping response of suppressing emotions in the face of discrimination or, you know, is a way for Black women to maybe have is a coping mechanism, and as a coping mechanism actually is a protective factor and mitigates the racial discrimination impact, right? Whereas the other factors, feeling intense motivation to succeed and feeling an obligation to help others, actually exacerbated the health risks associated with racial discrimination. So it's very interesting. Again, you know, when we talk about this idea of the Black woman schema, the strong Black woman, it's an interesting interesting concept, because again, there's positive as well as suboptimal outcomes as a result of taking on this role. So this is a quote taken from a blog post, a HuffPost blog post, and it was written by an African-American author, Mina B. So she's quoted as saying, "So when I look back at my younger self and I ask her, why didn't you get help? I remind myself how lonely and painful it would have been for me to publicly admit that I was depressed and suicidal. In my mind, I was raised to be a strong Black woman who could handle her own emotions, not asking someone to help me sort them out. How dare I need treatment for feeling worthless or for being bullied when I come from a lineage of ancestors who use strength and endurance as a way to survive? But maybe our survival tactics are actually causing us more harm than prosperity." So again, I think this quote is telling, because again, it really illustrates the yin and the yang, right, of this idea of our, you know, being proud of who we are and where we've come from, but also knowing that the strength and endurance that our ancestors had to show, okay, and pass along to multiple generations was a factor of the things that are now detrimental to us, right? So we protected ourselves because of structural racism, historical legacies of racism, right? And now we're at a point in time where we're starting to understand that there's a price to pay for the resistance that we've had to create for ourselves and empower ourselves, but at the same time, at what cost? So, and this is why it is so important to understand our history, acknowledge the impact that history has had on us, and the possibilities that we have now to understand that history and make a difference, especially as healthcare workers, individuals caring for our patients and for our clients and our consumers. So the main mental health effects that we look at with racism, the toll of the superwoman, are depression, anxiety, and loneliness. And then there are many other offshoots of, you know, different types of anxiety. There's social anxiety, there's generalized anxiety, depression, many types of depression as well. And this idea of being alone can then also, this feeling of loneliness can also exacerbate those experiences of depression and anxiety. So I wanted to touch a little bit on the intergenerational effect of the Black Superwoman hero, Black Superwoman role. So we talked earlier about the schema, right? This conceptual framework of how do we get to this point where we even have this identity of this Black Superwoman. And one of those contexts for developing this idea of the Black Superwoman is the fact there's this historical legacy, and it's also lessons learned from our mothers, our grandmothers. Okay, I mean, I can personally speak to the fact that even before I even knew about the term Black Superwoman, I saw what my mom went through, right? I saw and I heard from my mom's experiences, and this discussion of therapy or not therapy, church or not church. Do we keep our family secrets within our family, right? Those are things that are passed down and learned and normalized. So then you get to a certain age and you realize, okay, and I think this was a reckoning for me. What worked for my mother's generation, and I understand now, I understand some of the coping mechanisms she had to employ to survive and to make it, right? She was an immigrant to the United States. She had her own history, her own context that she had to armor herself to be able to weather being a new immigrant to this country, being a Black woman in this country, raising Black children in this country. So then when you start to understand, and then you start to put in the context of, oh, does this work anymore? Okay, can I take my armor off? Knowing that if I continue to wear my armor all the time, what lessons am I passing on to my children? Am I telling them, not even consciously, that we can't talk about our emotions, that our emotions don't matter, that they always have to wear the weight of the world on their shoulders? The answer is no, right? But that takes time, and it takes providers, it takes friends, it takes a community to start to unveil the consequences of this idealized stereotype of the Black woman. But also knowing that there are some benefits to it as well. And when we talk about this intergenerational effect, right, when we look at impact of racism on children, we know that mothers, right, even from the point of before a child is born, the impact of racism on the mother and the potential genetic impact is having with that child, maybe turning on or turning off genes for that baby that might be protective against particular chronic disease like heart disease, obesity, diabetes, or it might be turning on genes that now predispose us to those conditions. So it's already embedded one generation to another generation that gets passed along. And there's more science, there's going to be ongoing science to really understand what the true impact of or the additional impacts of racism that's had on an intergenerational on Black families and people of color intergenerationally. But as much as we know that there's this historical root to this Black superwoman, and I keep saying superhero, because I feel like even it's mythologized as well. Like we have to be heroes, right? Especially as healthcare providers, we have to save a lot of people. We save lives. So we also have that, especially I think maybe if we go into healthcare, that may be one of the reasons why we may have gone into healthcare. But that's just my theory. But just as much as there is this intergenerational inheritance of this concept, we can also change our mindset and understanding, and we can have even a more positive intergenerational effect once we start to really understand and deconstruct this idea. So I just want to show just a few minutes from this video. This was a mental health Expo put on by Charlemagne the God that many of you all know from the Breakfast Club. And it's a panel of advocates, educators, providers, and moderated by a well-known mental health, she calls herself a mental health correspondent, but she's also a well-known psychologist, Dr. Alfie Breland Noble. So I'm just going to share just a few minutes, because she asked a very important question. I wanted to have each of the panelists on the video share their response to the question Dr. Alfie asks.
Sisters and get them some flowers. All right, so we're going to start very briefly with one simple question for everybody. That question is, tell us why in this moment, Black women's mental health is important to you. So we're going to start and just go down the line. Go right ahead, Dr. Jackman.
We have carried our communities, our families, our organizations for many years, and there's a toll that takes on us. And I think it's time that we're recognizing that and that we're doing something about it.
Awesome. Thank you. Go right ahead, Dr. Walker. Well, Black women are powerful, immensely powerful. And at times, I think we don't necessarily tap into that power, but you all know that there's a lot going on in our society right now. And the timing is such that we tap into that power and we share it with the world as we continue to heal ourselves and heal our communities.
If you're trying to lose belly fat, stop doing cardio. This sounds kind of backwards, right? Well, believe me, it's actually.
Hello. As Black women, we tend to want to feel that the world is on our shoulders and we have to wear this Superwoman cape. And I believe today we're able to show you how you can take that cape off unashamedly and to walk in your power each and every day, regardless of what other people think or feel about you. I would just say that we're tired. And so now we're gonna sort of have a better understanding of how to break that word down into actionable steps so that we ain't tired no more. That's all I'll say. All right.
So as that panel talked about, right, this idea of why now we need to focus on Black women's mental health. But I know we're not totally just focusing on Black women's mental health, but at this point we're talking about it. Why it's important that we talk about Black mental health, women's mental health, period, right? It's because of this legacy, right? This legacy of not feeling like we can ask for help or feeling ashamed for asking for help, or not even really understanding what the help can provide us, right? How do we access the help when we don't know it exists, or what the legacy of an understanding of what mental health services are and are available for us. So we're going to talk a little bit later after the next presentation about some more ideal strategies for addressing Black women's mental health. But I think a lot of this is really going to come down to really understanding the historical context and legacy of structural racism on our health systems, both behavioral health as well as physical health systems, how we are educated as providers and that's providers across the board, mental health providers, community health workers, nurses, social workers, the gamut that really engage community workers in general, with agencies that work with families, mothers, children, really having an understanding of also cultural context, historical context, and also the policies, right? How policies are developed that make it harder to access services that are available, and then connecting those services directly and meeting clients and individuals where we can best serve them. And also understanding too that as much as, we might say we're culturally competent and we have translators or interpreters. We also still have to think about even what's the structure of our healthcare systems, and how people can access services. Even if we have telemental health services that, oh, that's going to be the rage, we're going to have more access for individuals. Well, the question is, does a person have reliable internet, reliable broadband? So again, those are those environmental, political policies, organizational policies, and things that we really need to consider, and how we really try to meet the needs of our communities. So again, this is another quote from Dr. Amani Allen. I referenced some of her work earlier. So she says, the problem is not that women need to learn to cope better with racial discrimination. The problem is racial discrimination itself and the need for interventions intended to address racial discrimination as experienced in the workplace, by police, and in society at large. Because I think it's sometimes I've heard people say, oh, just do this, right? Just go walk outside, just go meditate. And it's interesting, Dr. Allen, in one of her studies, it was Dr. Allen or Dr. Gizgombe, who talked about their study with women. They wanted to talk to women about the idea of implementing more self-care and using meditation. And many of the women in the study were very much interested in, oh, I would love to meditate. I would love to meditate. But there were some barriers for them to do that, right? And those are the things we need to consider. And some of the barriers that some of the women voiced were, when I come home, I don't have time, right? When they come home, they may have to cook, they may have to maybe study, they may have to get their kids ready for sports, or maybe get ready for another job. And so to think about, how easy it is for us to prescribe an intervention without fully understanding the context in which that intervention will be accessible, available, and easily incorporated into a person's day-to-day. So this idea, I love this idea of Dr. Amani Allen really talking about this idea of, when we talk about racial discrimination, I also read into this structural racism, right? How do we make it easier for people? How can we change workplace policies that allow it to be easier for families? This historical legacy of police violence against Black women, Black men, Black children also creates a stress. So then again, how do we educate law enforcement, the justice system? I mean, there's so many different sectors, housing, education, that really need to understand the context and historical legacies of structural racism, on how people have adapted, and then concerns about and questions about why someone isn't doing what we think they should be doing, without really fully understanding the context and historical legacy. So to me, this was very, very insightful. And lastly, before I hand off to the next brilliant speaker, I wanted to share some resources. I know in my practice, I've had parents ask me, they want to find a racially concordant or culturally concordant provider, behavioral health provider, someone that looks like them and has lived experiences. So at times it's difficult to find therapists, but if we as providers are cognizant of how can we create resource lists so that it's easier to help our families navigate, or our clients navigate, where to find therapists. So for example, Therapy for Black Girls is a podcast, as well as they provide a wonderful resource to find therapists. The next one is Effective Therapy for Black Women from the American Psychological Association. This provides an overview of the Black Superwoman and importance of therapy, and also provides some continuing education credits. And the last two guides are just additional resources for finding providers, and also really understanding the context on how to understand why therapy is important, and how to help people navigate the systems. So that's it. Thank you so much for the opportunity to speak with you today. And I look forward to any questions that you may have either now or after the next presentation. Thank you.
Thank you so much, Dr. Jackie, Dr. Duje. That was a really great presentation. Wow, a lot of, there was a lot of validating there. There's a lot of information, a lot of resources. And I really thank you for taking the time to offer that. I do wanna mention there is a reflection in the chat box that I wanna go ahead and I wanna read. And the reflection reads, how do we begin to understand what help is for us when we have been conditioned to inherently believe that as women, spelled WOMYN, which I like, we must carry the weight, figuratively and literally, of all beings while birthing, mothering, teaching, healing, leading, showing up, working, doing, existing, and being. While help is there, what does the concept of helping ourselves begin to look like? And I love that reflection. I love that question because it's also a question. And so I actually, would want to hear both your take and Miss Iris Rubio's take on this question. And then I want to open it up to see if anyone has any other questions on your content.
Oh, I think that's an amazing reflection, an important reflection. I think first and foremost, I think having forums like this helps to deconstruct the conditioning and unlearning the conditioning. It's not going to be an easy process, right? Because one, you now have to let it sink in. If it's now resonating with you, oh my God, right? All the stuff I've been doing is really, I'm helping, but it's hurting me, right? I mean, you have to kind of deal with that process. But I think it's the first step. And then the next step is to continue the conversation and find communities. And I know that's easy for me to say, find communities. There's got to be, again, this is part of the system. How do we make it easy for people to find communities to engage in this work? And a big shout out for the fact that I think we need more providers of color, Black, Hispanic, Latino, Asian American, all identities, right? Because the studies show that if there's similarities, if you can find someone that has a lived experience, looks like you, one, you're going to more likely to continue into that with the care and continue the relationship for help. And I'll leave it off to Iris.
And I also strongly believe in what you just stated, Dr. Duje, but then also when we do start stepping away, we do decide to start deconstructing all the cultural concepts that we have been taught and that we have learned. And as we step away from that, there is a feeling of loss. Some people experience feelings of failure because and there's like issues of like familial abandonment as we individuate. And so I also agree that it's very hard to find communities out there where we can get that support. And so we have the ability to start creating those communities. And so that's one of the things that I did for myself is I was very limited in the area where I live in finding, that support. And so we can definitely talk about that at the end of the presentation about how do we build these communities. Aside from, the formal resources that we get, how do we establish informal resources, right? Because formal resources are kind of like our last resource. And so I guess that's my take.
No, thank you so much. Thank you so much. So I want to give our audience an opportunity to ask questions. And so we've been reminding them to put any questions that they may have in the chat box, and it almost seems like one was already answered, which had to do with the recording. Yes, it will be available. But if you could also at this time right now, you could just use the regular chat as well, either or the question and answer chat for questions, because this is your opportunity. But I do have a question. So while I'm giving them a moment to maybe type and think, I do have a question, and which was partly, throughout your segment, Dr. Jackie, you did provide some suggestions But my question was, what are your recommendations for service providers to encourage women or Black women to recognize this potentially detrimental cycle, right? Of I'm the superwoman, to recognize that, and to also begin to obtain mental health and assistance. And you mentioned, I know you mentioned briefly meditate, and also as service providers, because that's who most of our audience is, to become an advocate for structural changes or a change agent.
Oh, that's a lot to answer. I don't know. I think a lot of women already know that there's an issue. I think it's having the not taking the shame and stigma away from admitting that. And I think what Iris said is so important, because I was thinking about it. I think it's true, right? I think for me, the experience of deconstructing some thoughts of what Blackness means and how I identify and show up as being Black, it's complicated, right? Any identity or intersectionality is so complicated, right? You start to realize, oh, I'm no longer this person, or am I? Can I still be a member of this group if I don't, quote unquote, have these experiences, or I want to get rid of, like, for example, in pediatrics, right, in parenting, this whole idea of gentle parenting, right? For some people, from what I've seen on, from some Black women, they'll say that this idea of, white people interjecting thoughts of what gentle parenting should be, right? So there's cross-cultural concerns. So this idea of, like, even therapy and mental health, depending on how you grew up, you have to unpack all that stuff. But I think first and foremost, if we're brave enough and we can create safe spaces, informally or formally, for women to say, I have an issue, or I need an issue, or again, as service providers, we have to be in the position where we're trained and feel comfortable to ask people, do you need help? So hopefully that answers the question.
And I have, there was someone who actually made a comment, said, I strongly feel that it's important to develop a network within states, just like you were alluding to, Dr. Jackie, to, so that there is a safe place to deal with this. Agreed. Most women know that this is happening, right? However, some women may be afraid to admit it. Mm-hmm. So yes, it's so true. We may know it, but it's like, how do we begin to take action to change it, or to avoid those detrimental effects?
But again, I think also too, when we think about, so I'm a healthcare provider, maybe ours could speak differently. But again, I think when we talk about structures, I think at times we need to make it easier for people to unburden themselves, right? And I think there's so much about on the person, but what are we doing to make it easier for people to do this? I don't have the answer to that, unfortunately. I wish I did. I'll come back next week with it. But you know what I'm saying? But I think that's really a big issue here, right? Because these are structures that have created this need to put on this armor.
Mm-hmm, yes.
Yeah.
I'm just preparing this myself, but you can continue talking. And yes, so we do have another question in the chat, and then we're going to go ahead and continue with the presentation. We'll take more questions a little later. So right now we have a question that says, you mentioned structural racism. How does Black women born and by choice navigate to overcome these challenges, or even recognize, I guess, the challenges related to structural racism?
I think it's on the structures to really do this, right? I think individually, right? I think as long as the more we can learn, right? Because even as service providers, again, we talk about, we have our own biases that can contribute to this, perpetuating, victimizing our clients and community, right? Or negative stereotypes. So I think there's one aspect. As an individual, learning your biases, acknowledging that, something's not right or wrong. You don't ask for help if you can, but also too, I think it's the systems and structures that really have to take ownership of their legacy, right? What have we done to inflict harm? And how can we, so there's also advocacy. If you're in a position where you feel safe in your organization, can you advocate? Can you be a part of some organization? Or sometimes, you know what, you just have to do it within your community, and you may not necessarily be able to change the structures, but you do what you can with what you have and when you can, right? It's all about, yeah, but that's a bigger, I think that really is bigger than anything, but I don't want it solely to be left on the individual, but at the same time, negate the fact that if we don't have individuals doing some of the work, then we're not going to change these systems. But this understanding of structural racism, but you know, these vote, make sure you have leaders empowered that don't ban books, you know, that don't create, that dismiss you and make you feel like you're the one that has the problem, you know, that, yeah, there's so many things. Yeah, I wish I knew the answer, but there's so many levels that we have to do, right? It's got to be done on so many different levels.
That's
but
true. And it should be just addressed at all of those levels, definitely at all of those levels. And Maria just also alluded to, you know, who should take on this, who should start, which discipline. And I think it's all the disciplines, mental health, you know, physical health, all the different areas. But I want to move on. I want to introduce our next speaker, Ms. Iris Rubio, and she is the founder of Miracles Counseling Center and owner of Serenity Child and Family Therapy, based in Los Angeles, California. Ms. Rubio has more than 15 years of vast experience working with children, youth, families, veterans, homeless, and LGBTQ populations. She's also managed programs related to family preservation, intimate partner violence, COD/AOD. She could explain that a little bit further. Child, youth, family, mental health programs, and trauma recovery. Please join me in welcoming Miss Iris Rubio, who will be our next speaker. Iris, you could go ahead and share your screen. I'm going to stop share.
Okay. Can you see it?
Yes.
Okay, good. Okay, so good afternoon, everybody. It's a pleasure to be here with you today. My name is Iris Rubio, and when I started thinking about this topic and I was invited to present on this topic is very close to home. I am Puerto Rican, and growing up in a household where the Superwoman Schema was not spoken about, but it was instilled in us non-verbally and sometimes verbally. And so I started thinking about this, and, you know, again, I am an entrepreneur, you know, who's constantly growing both of my businesses. I lead a team. I am a clinician. I am a presenter. I am a mother. I am a wife. I am a daughter. I am a sister. I am a mentor for startup entrepreneurs and mental health. And I also volunteer. And so don't get me wrong, you know, I've selected to do all of these things because I've wanted to, because I wanted to prove to myself that I can do it. But I also began to think about, when we're talking about the Superwoman Schema and what I'm instilling in my daughter and how she's understanding and viewing all of this, and as she develops, how she will also define success. And probably I have somehow ingrained the Superwoman Schema in her inadvertently. And then also I started thinking about how my son is actually processing all of this, and thinking that, you know, as where my daughter is thinking that she needs to have everything under control and she needs to achieve and conquer, you know, my son is probably thinking that that is the expectation of women, to have everything under control. And so it made me start thinking about, you know, what does it mean to have everything under control? And something that I learned is that my culture not only instilled this in me, but also propagated it. And at what cost? You know, it also made me think about the disparity of mental health services, as where Dr. Duge is talking from the macro perspective as to like, you know, systems and institutions. I started thinking also more on the micro level, right? And then also as service providers, like how do we, already knowing that there's a disparity in mental health services between Black, Indigenous, and people of color, you know, I started thinking about, you know, how do we start, you know, to dismantle this from a micro level, because we know that it takes time to change systems. And so it made me start thinking about, you know, the Latinx population in the US. And so according to the Census Bureau, right now, there are 62.1 million people in the United States that identify as Latinos. We have, according to the census, we account for 51.1% of the country's growth. And so we had, I think it was an increase, you know, in the last decade, there was a 23% jump in the growth of Hispanic population. And when I started thinking about that, and I'm thinking that, you know, Latinos account for over half of the country's population growth, you know, we are also the one group that is least likely to seek treatment. And, you know, I started thinking about the barriers, you know, we're just as vulnerable to mental illness as the rest of the population, right? And so, yet we experience inequities in treatment when we're talking about availability of services and then the quality of services, including, you know, that also includes the language barrier. So when we're talking about mental health and the transitional age youth, you know, age 18 to 25, majority of them suffer from severe mental illness, more than half of them, and they go without treatment. And so we know that if we leave mental health issues untreated, it's going to exacerbate all of their symptoms. And instead of using behavioral health or mental health as a preventive measure or preventive care, you know, treatment, intervention and treatment is a lot harder. And so another interesting fact that I found is that in comparison to the national average of 45% of the population, only 34% of Latinx people with mental illness receive treatment each year. And I believe someone in the chat asked, you know, how do we access those services, especially services that are costly? And I will talk about that in the end of my towards the end of my presentation. Another reason why, another barrier that we have is the stigma. You know, within Latinx individuals, we don't seek the treatment because, one, we may not, you know, recognize symptoms, first of all. The other thing is that we're very private. You know, we don't talk publicly about the challenges at home. This is a taboo in our community. You know, in many Latinx communities, we're familiar with the phrase, la ropa sucia se lava en casa. You know, you don't air your dirty laundry out in public. And so aside from not airing our dirty laundry, there's also that skepticism of systems, right? Because systems have violated our rights in the past. And so institutions, we're not fond of institutions. And so we decide, you know, instead of seeking services, we'll deal with it on our own, just because it is shameful to seek services. Another thing that we don't seek treatment for mental illness is out of fear of being labeled as locals or crazy, right? So we're bringing shame or unwanted attention to our families. You know, if people know that you're going to a psicólogo, you know, people automatically assume that you're not all upstairs. And so shame is huge in our community. We never want to bring shame to our family, or definitely bring negative attention, unwanted attention to our families. And then also faith communities may be a source of distress if they're not well informed. And so while we do seek our faith-based organizations, not everyone is trained in trauma-informed care and practices. And so, you know, we don't know how to support families dealing with mental health conditions where we're seeking other avenues. And so as Dr. Duge was talking about the Superwoman stigma, you know, this is the view that a woman can perform or will attempt to perform all of her duties, you know, typically associated with the different full-time roles that we play, right? So we're the wage earner, we're mothers, we're homemakers, we're wives. And so the pros of that is that there is a preservation of self and family as well as community, right? We keep everything together. The cons of that is the strain that we place not only on ourselves, but on relationships, the stress-related health behaviors and how it's affecting our system physically and mentally, how we are, and you know, somatically keeping all of this inside of us. So that's stress embodiment. And then, you know, ultimately culminating in mental health issues. So while, you know, it looks very glamorous because we're keeping it all together and the picture looks great, right? When we're preserving ourself and our family, it definitely has a detrimental effect on our well-being. And so as we talked about culture and how we came to be with this concept as a Latinx woman, you know, I started in my own experience, I started thinking about how my culture shaped my identity, you know, that has to be taken into account, especially when we're talking about gender roles, which are very hard and instilled in the Latina, Latinx community and the implications that they have on mental health. And so there is an intersectionality in all the different roles that we play, right? So culturally, you know, our nationality has a lot to do with it, our sexual orientation, our hobbies, our personalities, our gender identity, our race, our ability, our language, our religion. So all of these things shape how we start viewing ourselves in this superwoman schema or stereotype. And as I started doing some research about how did we get here, you know, how as Latinos or Latinas did we get to this notion where women should have everything under control, right? And so I teach intimate partner violence classes, and the term Marianismo comes up all of the time. And so how many of you are familiar with the term Marianismo? Many of us are very familiar with the word machismo, right? But Marianismo is something that we don't often talk about in our culture. And so anybody familiar with the term Marianismo? I see Rosa said that she's familiar. Okay, good. So some of you have heard. Okay, and so I will explain to you, for those of you who are not familiar, the term Marianismo defines the gender roles of Latinx women. And so Marianismo is a female gender role that is tightly linked to machismo and to Roman Catholicism, right? So in the times of colonialism, this was brought to us, right? And so it's that a woman is substandard, has substandard status in society. And it also draws attention to women's unrealistic or idealized gender roles. And so Marianismo is based on the image of the Virgin Mary, who's not only virginally pure, non-sexual, and self-sacrificing, and must remain virtuous, modest, and spiritually superior to man. And so when we're talking about Marianismo and the Superwoman effect, that's exactly where we get it from. So in this self-sacrificing mode, we have to give it all up for the betterment of our family, right? So it's not about us. It's about everybody who is under us. And while we do all of that, we still have to maintain this status. We have to still maintain this virtuous, modest, and spiritually superior being, because we don't want to bring shame to our families. And so the gender roles are idealized. And all of this comes from machismo. And so when I started thinking about, this strong or exaggerated sense of manliness, and, when we talk about machismo, we always think, the negative aspects of it. And I definitely have always associated machismo negatively, right? Because we're talking about hypermasculinity, we're talking about rebellious behavior, that male dominance, profane language, sexual prowess, physical strength. And then I started doing a little bit more research, and I started thinking about, what are some positive aspects of machismo? And so I started to think about, and also what the research says, it's that it's associated with hard work and work ethic. It's courage, it's being a caballero, it's protecting and providing for the family and meeting social obligations. The consequences of that is that it's exaggerated manliness, the paternalism in it. It propagates violence and abuse and control. Definitely there's alcoholism, there's vengeance, there's hypersexuality and risk-taking behavior. And so sometimes we're like, okay, well, what does machismo have anything to do with the Superwoman, schema? Well, it's all intertwined. Machismo propagates this hypermasculinity, right? And so the male is just doing what they're supposed to do. They're supposed to do the hard work and they're supposed to come home, as where the woman is supposed to stay in the home, remain virginal, remain pure, remain modest, and then take care of everything and anything that deals with inside the home. And so with Marianismo, there are core ideals that are ingrained. And the first one is familismo, where a woman needs to be a good wife, a good mother, a good caretaker. Definitely needs to instill respeto or respect. So a woman should be modest in her behavior and not talk about sex and not engage in sex for pleasure. And then she must be simpática, she must be charismatic, a woman that avoids all conflicts at all costs, and silences herself, right? So she must suppress her opinions and her emotions just to maintain their harmony. And that's part of being a superwoman. It's maintaining the family, the harmony within the home. That's exactly what our culture defines, what it means to be a good woman. You keep your family together, you instill respect, not only for yourself, but for your family, because you want, your family to represent you well, right? So there is no vergüenza coming from it or shame, right? And then you must be simpática. So like that, you can just maintain the harmony and have no opinions and no emotions. And so when we start thinking about Marianismo and mental health, studies have found that female gender roles have been related to a number of adverse health consequences. And so we definitely know that there's a clear link between sexism and gender inequality and the rates of psychological discomfort, which include depression, anxiety, as well as it impacts sexual health. This definitely propagates domestic violence or intimate partner violence. So it's very important that when we are, as service providers, when we're in front of a client, we adequately screen, right? The practice of self-silencing is one aspect of Marianismo that the research shows has greater rates for anxiety and also depression for women. And then although it keeps harmony, in the relationships, there's a loss of self that comes with it. So we are self-sacrificing when we are taking on this superwoman role. And so we definitely see an increased rate of psychological discomfort. And so as we start talking about all of these roles that we play, we start thinking about imposter syndrome. I'm not sure if any of you are familiar with imposter syndrome. And this is a term that we technically or typically use amongst professionals, but then it also has to deal with on a personal level. Because as a superwoman who is keeping the familismo, the family intact, is bringing respect to her family, is playing the woman, the caretaker. We're nurses, we're counselors, we're wives, we're daughters, we're sisters. And then we start thinking about our upbringing, and then we're thinking about, wow, my mom and my grandma and my tia abuela did all of this, right? They tended the home, they took care of the kids, they had the house, spotless. Everybody had their lunches, uniforms were ironed. Everybody had their schedules in their agenda, and they kept it all together. And then I started thinking about, oh my God, like, how do I meet that expectation as well? How do I not fail? I have a lot more resources than what my ancestors had, right? And so definitely a sense of imposter syndrome comes along, because with imposter syndrome, we have this belief that one is a fraud, right? And that we will be eventually exposed. So I'm doing all of these things, and just like my mom did all of these things and made it look so easy, right? Sometimes we feel like if people really knew how I feel inside, it would be awful. I would be exposed, right? And so this is an irrational thought that we have despite our achievements. And so, when I started thinking about imposter syndrome, I was thinking like, yes, my grandma made it look so easy. My grandma had breakfast, snack, lunch, snack, dinner, snack, all together for everybody. And people were coming in and out of my house, my tias, my tios, my primos, my primas. And she still managed to get laundry done, had the house done. My grandma was an Army vet. And so she was still active in the military. And then my mom was a working woman who also tended the home. And so how do I live up to that expectation? Is it okay for me to take off my cape? You know what I mean? And the answer is absolutely not. I can never take off my cape, right? Because it can also be a sign of weakness. It's letting my family down because I'm now no longer showing that familismo. And so 45% women of color have been the only person of their gender. And so in intertwining obstacles of racism and sexism, Latinx women are a lot more vulnerable to imposter syndrome. This is what the research says, just because of how all of this was ingrained in us for many generations, and how it continues to be perpetuated in our household. So it doesn't matter how much education we get, it doesn't matter how much we achieve, this is still the expectations that our families have of us. And so the research also said that it's higher for women of color in STEM professions. We're seeing a lot more. And so, Isabel, I never thought about imposter syndrome in the context of the family. And so as I started, I'm trained in family systems. And so I started thinking about, this has to go across, this isn't just professionally, or intellectually, this is something that can be found in our family systems individually, because I know for myself, and I have no problems disclosing, this is part of being a mental health clinician. I come across that a lot, I come across, I think of all of the ribbons and diplomas and certifications that I have. And then I always think, is that even enough? And so as we work with these populations, and so this is the what I was saying is, my grandmother and my mom made it look so easy. And when they made it look so easy, as I've gotten older, I've discounted its value, right? And so that's where the imposter syndrome lies, and that's why we work ourselves to death, because since they made it look easy, we don't really give ourselves credit for everything that we are doing, right? And I think that it's important, right? And so as yes, Dr. Jacqueline, Dr. Duje, I do believe that is being enough, or am I enough, is definitely very common. And it definitely looks easier, but it's hard. It's very hard because at the end of the day, we're so exhausted that we don't even feel like, we've given ourselves to everybody in our family, that we have very little time for ourselves. And so as we talk about the Superwoman schema and its components of machismo, Marianismo, and the imposter syndrome, and how it all affects the mental health, and as service providers, we have to be very cognizant and aware of what are some of the symptoms or behaviors that our clients may come in with, right? And so when we're talking about depression, we should do screenings, right? And so there are different screenings out there, like the PHQ-9, which it works really great with depression, where it asks about, loss of interest in daily activities, if there's any sadness or feelings of emptiness or hopelessness, tiredness, low self-esteem, trouble concentrating, avoidance of social activities, feeling guilt or worries over the past. It definitely impacts our appetite, our overeating, and our sleep problems. When our clients are reporting anxiety, they may report that they're feeling restless, they're feeling wound up, they're feeling on edge. In the Latino community, we say ataques de nervios, right? And so, they'll come in and they won't say anxiety. They'll just say, yeah, tengo los nervios trepados, right? So like my nerves are really high. But when the client starts saying that they're feeling easily fatigued or overly tired and they're irritable, or that they have headaches or muscle aches or stomach aches or unexplained pains, difficulty controlling feelings of worry, they have sleeping problems. Those are the key words that we need to be looking for. With anxiety, we could use a screening like the Beck. The Beck is really good at, it's also a screening tool for anxiety. And then with our people who don't ever think that it's depression or anxiety, because that doesn't happen in our families, right? Our people typically have somatic symptoms, right? And so that's the constant worry about having a potential illness. But we will definitely say that we have pains in our joints, we have stomach issues, we have nausea, we have migraines, we have muscular pains, we have back pains, we have respiratory issues, but we will never associate that with mental health. And so it's important that when we do these screenings, we talk about those things with our clients. And then we also have to talk about substance abuse, because it's a way to self-medicate and make all of these symptoms of depression, anxiety, and all of these somatic symptoms at least alleviate for a little bit. And so it's important that we do the screening. We can do the DAST-10 screens for substance abuse and for co-occurring disorders as well. And so as far as service provision, it's important as service providers, as we try to reach out to our communities, it's important that we have an understanding of the population that we're serving. We have to understand the people that we're working with, right? So historically, socially, we have to understand the culture, immigration patterns, socioeconomic statuses. We have to understand politically how our communities are made up. Our community is huge, right? So we have US Latinx Latinos. We also have immigrant Latinos. We have Caribbean people, Central American people, South American people. And while we all eat rice and beans, we all season them differently. And so it's important that we also take that understanding when we are working with the many, many ethnic populations. Our services need to be empathic. We need to be genuine. We need to be culturally humble and affirming. as well as being linguistically competent, right? And so, I live in Los Angeles, I work in Los Angeles, and I'm Puerto Rican. And so it's usually, well, we know that Los Angeles is predominantly Mexican. And so when I do my informed consent and I'm getting to know my client as we're engaging the clients, I let them know if there's any word that I may use in Spanish that may not sound familiar to you, please feel free to share, with me that, you don't quite understand what I'm saying, or if there's an alternative word that I can use. And so I've learned how to communicate using my word and Central American words, Mexican words. So like that, I can make our clients feel a lot more welcomed and secure, and not trying to change their vocabulary just because I'm their service provider. I definitely don't believe in translation of services. And so it is important that we connect our clients with clinicians that look like them and that have had, that have a similar background or experience. As I said, in service provision, screening tools for depression, anxiety, as well as trauma, it's important, to understand that Marianismo, Machismo could be traumatic. And so we can use the PHQ-9, the Beck inventories, the PCL-5, which screens for trauma, and then definitely do the ACEs, the adverse childhood experience, just to see where your clients are. And then the other thing is making sure that services are client-centered. We meet the client where they're at. The client is the expert of their own life, right? And so it means that we're including the client in treatment decisions. It means that we're meeting the client where they're at. And we leave our own worldviews outside, because maybe my Superwoman schema, the way that I have processed it, may be different the way that that the client sitting in front of me may have learned the definition. And even though they're similar, our experiences may be different, because maybe our socioeconomic status may have been different. Or, I lived in PR, I was raised in PR up until the age of 12, 13. And so that may look different to someone who may have been raised in the tri-state area their entire life. So it's just questioning, with care and love when you're talking to your clients. It's also, if possible, at our agency, we have a single point of contact, a single point of entry. When we're talking about, institutions and systems, it's already intimidating and scary for our clients, especially if they don't speak the language, right? And even when they do speak the language, the bureaucracy, there's so much bureaucracy, right? And so what we do at our agency is that one clinician is assigned, and this may not be feasible for all agencies, but what we do is we assign one clinician, and this clinician is the person who handholds and does the warm handoffs between providers. And we don't pull out until they're fully engaged. So like that, the client doesn't have to be calling, they don't have to call many different providers. One person does all of the appointments and does all of the engagement, and then eventually does the warm handoff to make sure that they're well taken care of and they're being welcome and received on the other end. The other thing is using evidence-based practices in treatment. On the front end, using like motivational interviewing. And then if you're on the clinical side, there's an array of, treatment modalities. So we have cognitive behavioral therapy, trauma-focused cognitive behavioral therapy. We use cognitive processing therapy in trauma. We use narrative exposure therapy in trauma. We have EMDR. We have brain spotting. The most important thing with these using evidence-based practices in treatment is that we have fidelity to the model. We know that if we implement these treatment modalities the way that they're supposed to, we'll have successful outcomes. The other thing that we do, and I think it's very important, is that we provide services from a multidisciplinary team approach, right? And so there's always consultation going on with colleagues. There's always training going on, and that there's everyone who's treating the client is present. So like that, there's no breakdown in communication and in treatment. We also have to address our own biases, our prejudices, and our own countertransferences. And so for those of you who are not familiar with the word countertransference, it's when a client comes into, the session or into your intake or into your interview, and they start talking about something that starts sounding very close to home. And we start having feelings about it. And so it's important that we seek supervision for that. And then lastly, self-care. It's very important that when we're talking about these subjects, the Superwoman Schema and how it has depression and anxiety and somatic and substance abuse and trauma, that we take care of ourselves because we want to decrease vicarious trauma, right? And so I'm not sure if you guys are all familiar with the word vicarious trauma, but vicarious trauma is when we actually start absorbing our clients' traumas and we can't decipher between their traumas and our own. It will definitely cause us to have burnout. And so what good will we be if we're completely burned out when we are providing services to our client? And then lastly, we'll definitely experience compassion fatigue. And so it's very important that with the self-care, that's not something that's left just for us to take care of. It's also the responsibility of the organizations that we're working with. It's important that they implement policies and practices that will reduce the chances of vicarious trauma, burnout, and compassion fatigue amongst our staff. And so in conclusion, the Superwoman Schema has an impact on the psychological health status of our clients. It's the belief that we must balance our profession, our family, our home, and our social activities. It's the understanding that culture is primordial. Our mamas, our abuelas, our tias, they made it look so simple, but our experience is very different, and feel comfortable knowing that. And then when it comes to service provision, it's important to have as many resources and also for ourselves be well trained, so we can not only engage, but so that we can also retain the clientele who we are serving. And so I also had resources. And so these are some of the resources that are specific to the Latinx community. We have Latinx therapy, Mental Health America resources for Latinx Hispanic communities, NAMI's Compartiendo Esperanza, therapy for Latinx, inclusive therapy for BIPOC, and then the American Society of Hispanic Psychiatry. And so again, my name is Iris Cruet Rubio. It has been a pleasure presenting to you this very not only interesting topic, but I think a very personal topic for me, because I can definitely relate to the many different aspects of this Superwoman Schema. And I hope that you have enjoyed my presentation. If you have any questions for me, please feel free to put them in the chat, and I would be more than happy to answer them for you.
Thank you so much, Iris. A lot of fascinating information from the both of you. I'm sure, and I was reading the chat box throughout both presentations, and a lot of people were commenting on your content and how it's, agreeing, contributing, related content, and really just, sounding off. And that's great, because we don't have, and I realize the time, so I apologize, but we don't talk about this as much as we should. And even amongst, I have to say, and you ladies, Dr. Jackie and Iris can let me know, even amongst our own personal networks, we don't talk about it. Because I remember I have a friend, and, she looks like she's all together, right? Full-time job, a family and everything. She does all these things. And then one day I found out, and some of you are going to laugh, that she outsources her laundry. And I'm like, how dare she? Here I am. You know what I mean? So that's, and we don't even talk about those little things that we can do to just lighten off, literally lighten the load, and how we can take care of ourselves. So this is really fascinating information. The imposter syndrome, I didn't know that's what it's called. I understand it completely and I knew about it. But these are things that it's really so great to be able to educate ourselves, enlighten ourselves. And then as service providers, because that's who we are as service providers in this group, what can we do to help individuals that we see every day, or even our other colleagues and other service providers that we work with? But I'm gonna step back and be quiet, and I want you all, I want to give you an opportunity to ask questions. Please, these ladies, they're still here. I know time is running out or has ended, but I still want to give one last opportunity for people to ask questions.
You know, I was just reading Josefina's, Josefina wrote that in many occasions, it's hard to recognize within our people the mental health aspects, and that it's very sad. And that many times, because of lack of services, many of our people go without treatment. And so in California, my agency is actually recognized as a trauma recovery center in the state of California. And all of the services that we provide to the community are free. So we provide the psychiatric services, the clinical case management, individual therapy, group therapy. And there are many resources within the many states, across all 50 states and territories, where clients are able to receive free mental health services. For example, with us, immigration status, legal immigration status is not needed, and neither is insurance. So we can treat anybody who walks in through the door. And so there are many agencies statewide and nationally that do provide free services.
Yeah, we need to really learn about that. I know, I just want to interject, Iris, because I know Dr. Jackie has to leave, and I want her to just be able to maybe make a final comment to the attendees or something like that. So Dr. Jackie, please.
Oh, I echo everything that that Iris mentioned, and I learned so much even from your presentation. Again, because again, being a direct service provider, right, whether it's mental or behavioral health, this is so relevant. I mean, I work with families and children, but I as I'm listening to even Iris's presentation, I'm taking in, how do I take this information back to better serve my families? And